Welcome to week 13 of Nursing 487. In this unit, we'll cover alterations in immunity. The objectives of this unit are to understand and critically analyze the etiology, clinical manifestations, and nursing assessments and diagnostics related to the immune response, inflammation and wound healing, alterations in immune response, including allergic reactions and anaphylaxis. In general, the human body does a really great job at protecting itself from injury and infection. Immunity is the body's ability to resist disease, and immune responses serve three functions in this process: defense, homeostasis, and surveillance. Defense is the body's ability to protect against invasions by microorganisms and to prevent infections by attacking foreign antigens and pathogens. Homeostasis is when damaged cellular responses are ingested and removed. And surveillance is when mutations continually arise in the body, which are normally recognized as foreign cells, and then they are destroyed. An antigen, as you know, is a substance that elicits an immune response, and all of the cells of the body have antigens on their surface. There are several different types of immunity. The first is innate immunity, and this is the first line of defense against pathogens. This immunity provides a non-specific where neutrophils and monocytes, which are the white blood cells, mostly are involved in this type. It's not antigen specific, so it responds really quickly to an invading organism. When we look at acquired immunity, it is the development of immunity, and this can happen actively or passively. Immunizations, or pathogens invading the body, are examples of active immunity. So when the pathogen invades, it causes the body to activate antibodies and lymphocytes, and the body then creates a memory. So if the organism invades the body again, it will react quicker, remembering what it was before. With passive immunity, the host receives the antibodies to an antigen, and this can happen naturally or artificially. An example of this happening naturally would be when a neonate receives immunoglobulins from its mother's colostrum in the breast milk. When we look at the lymphoid tissues, there is both central and peripheral tissues. The central lymphoid tissues consist of the thymus gland and the bone marrow, while the peripheral organs include the lymph nodes, the tonsils, the spleen, gut, the genitals, the bronchioles, and there's also skin-associated lymphoid tissues. From here, you can see this in figure 16.1 from your Lewis text. Lymphocytes are produced in the bone marrow, and then they move to peripheral organs. The thymus here helps to differentiate the mature T lymphocytes, and for that reason, the thymus gland is essential for cell-mediated immune responses. When antigens are present in the body, they move to the lymph nodes and interact with both the B and the T lymphocytes as well as macrophages. The lymph nodes here help filter foreign materials out and circulate lymphocytes. Lymph tissue is also important to remember this, found in the respiratory tract and the GI tract, that helps to protect the body from microorganisms. Tonsils here would be an example of lymph tissue. The spleen in the peripheral lymph is the peripheral lymph organ that mainly filters foreign antigens from the blood.
The immune system defends the body against foreign invaders, such as bacteria or parasites, and against internal invaders, such as cancer cells. It also can react to substances that contact the skin, are inhaled, such as pollen, or are eaten. White blood cells are an important part of the immune system. When they are needed to defend the body, they move into the bloodstream and travel to wherever they are required. The immune system can be divided into innate and acquired immunity. The innate immune system responds to invaders immediately without needing to learn to recognize them. The innate immune system involves cells called phagocytes, which are able to ingest invaders. Phagocytes include macrophages, neutrophils, monocytes, and dendritic cells. The thymus gland is part of the acquired immune system, in which B and T cells learn to recognize and remember foreign substances called antigens, so they can be attacked more efficiently in future encounters. B cells are white blood cells that produce antibodies. Antibodies bind to the antigen of an invader, tagging it for attack. An autoimmune disorder may occur if antibodies mistake the body's own tissues for invaders, such as occurs in rheumatoid arthritis, where the immune system attacks the body's own joints and tissues.
So we're going to have a look at what happens in the normal immune response. The cells involved in this process are antigens, antibodies, and cytokines. So antigens here are the substances that the body recognizes as foreign, and when they come into the body, it elicits the immune response. Most of these cells are composed of protein. Antibodies are the immunoglobulins produced by the lymphocytes in response to this recognition of antigens, and the cells that are involved in the immune response include both mononuclear phagocytes and lymphocytes. The mononuclear phagocytes includes monocytes in the blood as well as macrophages in the body. And these are important because they capture the antigen and then present it to the lymphocytes. The antigen then stimulates either the humoral response or cell-mediated response from the immune system. Lymphocytes themselves are produced in the bone marrow, and then they differentiate into B lymphocytes or T lymphocytes. These B cells differentiate into plasma cells when they're activated, and they produce antibodies or immunoglobulins. Cells that migrate from the bone marrow to the thymus differentiate into T lymphocytes, and these are thymus-dependent cells. The T lymphocytes can be categorized as cytotoxic or T helper cells. The T cytotoxic cells attack the foreign pathogen antigen and release cytolytic substances that destroy the pathogen. These T cells, some of them remain as memory T cells, not going and attacking it. So if it's there and an antigen presents itself a second time in a second invasion, it makes a stronger immune response. The other type of T cells, the T helper cells, are involved in the regulation of cell-mediated immunity or humoral antibody response. So these T helper cells make cytokines that kill microbes in the body. Natural killer cells are also involved in cell-mediated responses, and they are large lymphocytes that kill the infected virus cells, infected tumor cells, and even transplant grafts. Dendritic cells play a role here in cell-mediated immunity and responses as well, and they are found on the skin and the lining of the nose, the lungs, the stomach, and the intestines. And what they do is basically capture antigens on the skin or in mucous membranes and then transport it to a T cell for destruction. Cytokines are involved in the immune response, and this involves a complex interaction of T lymphocytes, B lymphocytes, monocytes, and neutrophils. So these interactions depend on cytokines, which are secreted in the white blood cells, and they act as messengers between the cells and instruct the cells to alter their proliferation, differentiation, secretion, or activity, depending on what's occurring in the body. Interleukins and interferons are types of cytokines that are involved with the immune response.
Activation of the immune response typically begins when a pathogen enters the body. Macrophages that encounter the pathogen ingest, process, and display the antigen fragments on their cell surfaces. Macrophages with antigen fragments displayed on their surfaces are called antigen-presenting cells. An antigen-presenting macrophage interacts with a T helper cell that can recognize the same antigen. During the interaction, the macrophage releases a chemical alarm signal called interleukin-1, which stimulates the T helper cell to secrete interleukin-2. Interleukin-2 causes the proliferation of certain cytotoxic T cells and B cells. The immune response from this point follows two paths, one using cytotoxic T cells and one using B cells. Normal cells of the body that become infected can also digest some of the pathogens and display antigen fragments on their cell surfaces. The body makes millions of different types of cytotoxic T cells. Each type is able to recognize a particular antigen. The cytotoxic T cells that are capable of recognizing the antigen displayed on the surfaces of infected cells bind to the infected cells and produce chemicals that kill the infected cell. Death of the infected cells results in destruction of the pathogen. B cells also come in millions of different types, each able to recognize a particular antigen. When B cells become activated by T helper cells, they differentiate into plasma cells. These plasma cells become antibody-producing factories, flooding the bloodstream with antibodies that can bind to the antigen involved in this infection. Antibodies bind to the antigens on the surfaces of the pathogens, marking them for destruction by macrophages. Some of the B cells do not turn into antibody factories, but instead become memory B cells that may survive for several decades. Because of these memory B cells, the secondary immune response to a future infection by the same pathogen is swifter and stronger. This powerful secondary immune response is what gives immunity to some diseases after you have had them once or after you have been vaccinated.
So now we're going to look at a quick comparison of humoral and cell-mediated immunity. Humoral immunity is antibody-mediated immunity, what happens is when bacteria enters the body, it may encounter a B lymphocyte specific for antigens on the bacterial wall, and the B lymphocyte recognizes the antigen because it has receptors specific to that antigen. The B cell is then activated and changes to a plasma cell that secretes the immunoglobulins. These immunoglobulins are IgG, IgA, IgM, IgD, and IgE. The immune response becomes evident about 4 to 8 days after this infection. In contrast to this immune response, these are initiated through specific antigen recognition by T cells and are termed cell-mediated immunity. So there are several types of cells involving T lymphocytes, macrophages, natural killer cells, and cell-mediated response. This helps protect the body from viruses, bacterial fungal infections, tumors, and hypersensitivity reactions. So both humoral and cell-mediated immunity are needed for the body to remain healthy. So again, looking at the humoral immunity, that is the antibody-mediated immunity, and antibodies are plasma glycoproteins that can be classified according to their chemical structure and biological activity. So again, here, your IgG, your IgM, your IgE, your IgD, and your IgA. So IgM is responsible for the primary immune response, and it forms the antibodies as well to the A, B, O blood antigens in the blood groups. IgG is the secondary immune response that happens. And on the diagram here, you can see both of these where IgM is initiated first and then IgG follows as a secondary response. IgG is the immunoglobulin that's responsible for the symptoms of an allergic reaction. So this one is often one that is measured when there's testing done for allergies. And this one fixes to mast cells and basophils, so it helps in that defense against parasitic infections as well. IgD assists in the differentiation between B lymphocytes, and it's present on the lymphocyte surface. IgA aligns with the surface of the mucous membranes and protects the body. So when you look at IgA and the body secretions, you'll see this activated in tears, saliva, breast milk, and in colostrum as well. So it's important here to mention that there's some differences in the immune response with the aging population. There is a decline in the immune function and an increase in the incidence of tumors with increasing age. There is also a greater susceptibility to infection as a decreased cell and mediated immune response. There's also a decreased delayed and hypersensitivity reaction. There's differences in the production of the interleukins 1 and 2, and the proliferation response of T cells and B cells is also decreased. So while an increase in autoantibodies is seen. In the bone marrow, the function is relatively unaffected by increasing age, but there is a decrease in the size and the activity of the thymus gland. And T cells and B cells tend to show deficiency in activation with increasing age. Overall, these changes in this population creates a greater increased risk for infection and a decrease in an immune response overall. So now that we've looked at what happens in the normal immune response, we're going to look at what happens in the altered immune response, or in this case, an allergic reaction. So when the immune response is hypersensitive or overreacts to a foreign substance, hypersensitivity disorders like allergies or autoimmune diseases can occur. If the immune system is underreactive, this is when we can see infections, malignancies, or immunodeficiency diseases occur. A hypersensitivity reaction is when the immune response is overactive against a foreign antigen or even against the body's own tissues, and this results in tissue damage. For people with autoimmune diseases, they have a hypersensitivity response because of the body not being able to recognize self-proteins, and then it reacts to itself against self-antigens. So there are 4 different hypersensitivity reactions, and these are listed on page 267 and table 16.7 of your Lewis text. Anaphylactic cytotoxic immune complex and delayed hypersensitivity reactions or allergies, or what we refer to as type 1 hypersensitivity reactions, are seen most frequently. Common allergic reactions include anaphylaxis as well as atopic reactions. These atopic reactions are your allergic rhinitis, so your runny nose, the atopic dermatitis, which we see as eczema or urticaria reactions, which are like hives. We can see these as in patients, as well as like angioedema, and these are all common types of hypersensitivity reactions. So the one that we'll talk about is type 1 anaphylactic, and this one is mediated by the IgE antibody. So this type of altered immune response occurs only in individuals that are highly sensitized to specific allergens. IgE antibodies will attach to most mast cells and basophils, and within those cells there's things like histamines, serotonins, leukotrienes, eosinophils, or chemotactic factors of anaphylaxis, or ECFA. There's kinins or bradykinins, which are chemical mediators, and in the Lewis textbook, there's a list of these chemical mediators with further descriptions on page 267. So the figure here on the slide demonstrates when an allergen enters the body and IgE antibodies are produced and bind to the mast cells and the basophils. With subsequent exposure, that allergen attaches links with IgE that is bound to mast cells or basophils, and it causes degranulation of the cells, which then releases those chemical mediators. It's the chemical mediators that are responsible for attacking other cells that cause the symptoms of the allergic reactions. So when we look at the clinical manifestations of allergic reactions, these are all specifically related to the chemical mediators. If the reaction remains local, we'll see different clinical manifestations than if it becomes systemic throughout the body. So if the reaction is local, a wheal, a flare reaction will occur. So this is like a rash to the area that includes an allergic reaction to a specific allergen. But if other organs become involved, like the GI system, respiratory system, skin, intravascular compartment, these all can become affected, and then we'll see those specific clinical manifestations related to those specific systems. Then we'll see things like bronchoconstriction, edema of the airways, urticaria, which is the hives again, or itchy welts that patients can get. Hypotension and angioedema can occur here, and that's that swelling of the tissue under the skin that can affect the face and the throat. Sometimes patients will have nausea and vomiting, specifically if they've ingested allergens or eaten something that they're allergic to. And here you might end up with diarrhea and also systemically all over rashes and pruritus that can occur. So common allergic reactions can be anaphylaxis or atopic reactions. With anaphylaxis, there is severe, potentially life-threatening allergic reactions, and then atopic reactions are those that I mentioned already, like the allergic rhinitis or the runny nose, or asthma or eczema or atopic dermatitis. And like I said, they can also have that urticaria or angioedema. So maybe you've heard of the atopic triad, which we see sometimes in kids where they have asthma, atopic dermatitis, and allergies or anaphylaxis, and that's what's considered to be the triad of the A's. In anaphylactic reactions, they occur suddenly in hypersensitive patients after exposure to the allergen. So they may occur following parental injections of drugs, especially antibiotics, and you see this with the administration as well of blood or with insect stings like bees or wasps that are often the trigger. Another common source can be from food, and this picture is from the movie Hitch, if you can remember that, or if you saw it, in which he experienced an allergic reaction to seafood. So you can see the side effects that he has here with the edema and the swelling to his face. In your Lewis textbook on page 268, you'll see this diagram here on the slide of some of the clinical manifestations are shown, and it shows the target organs that are usually affected in anaphylaxis. The initial symptoms here the patient usually presents with is edema and itching at the site of the exposure to the allergen, and that can be different depending on if it's ingested or if it was a bee sting or whatever. And from here, anaphylaxis can develop quickly into shock, so close monitoring is very important and is required. The monitoring for these patients, like I said, needs to be done very closely and very quickly to give them the treatment, which is really usually the administration of epinephrine. If these patients do develop shock, it will present with rapid weak pulse, hypotension, dilated pupils, dyspnea. You'll possibly see cyanosis and airway edema, which usually worsens the symptoms as well. So after an allergic disorder is diagnosed, the treatment here is aimed at reducing the exposure to the offending allergen. And if the symptoms are treated, if necessary, sometimes we also can do desensitization through immunotherapy, which can be completed if they're severe responses. In completing the assessment for a patient for allergies, you want to follow the same approach beginning with your subjective data, and this will include the past health history and then what the symptoms are that they're experiencing. Some of the common ones here can include vomiting, diarrhea, fatigue, hoarseness, cough, dyspnea, stinging in the eyes and throat and nose, and then you want to start again with your head to toe assessment, working through the different systems. Then you want to examine the integumentary system for rashes, wheals, flares, papules, vesicles, drying, scaliness, scratching, and irritation. When examining the eyes, observe for conjunctivitis, tearing, rubbing, or excessive blinking, or also for dark circles under the eyes. You want to assess the ears for problems with infections or irritation. And when looking at the nose, you want to look for polyps, congestion with itching or running. And in the throat, observe if it's red or if they're continually clearing their throat. And also looking orally, you want to look if they have swollen lips and if they have palpable lymph nodes as well. In reviewing the respiratory system, you want to look for issues such as wheezing or stridor, any evidence of constriction there. And it's not uncommon to see patients with seasonal allergies that have some of these same symptoms, which often can be mixed up. Some of the possible diagnostic findings are an elevated eosinophil white blood cell count, and they'll see these with an increase in the serum IgE levels. Chest and sinus x-rays here may be abnormal as well, and if skin testing is completed, they'll have positive findings. If a patient has anaphylaxis, that assessment will need to be rapid, and clinical manifestations will be much more profound. So in examining the neurological system, assess for feelings of impending doom, dizziness, or tingling to the skin. An integumentary system, again, may show the rash, angioedema, erythema, redness, and that urticaria, hives, wheals, welts. We're going to see decreased peripheral resistance, which is very important to remember as a common finding here. The respiratory assessment will show evidence of a narrow airway, and that's what will result in that wheeze or in striding that is caused by that bronchial constriction. I want you to remember that is an important trigger, that an onset of that quick reaction of wheezing and stridor should trigger you to think of bronchial constriction caused by an anaphylactic source. Patients will demonstrate difficulty breathing here with an increased respiratory rate, and they can even end up in respiratory arrest if the edema obstructs the airway. Cardiovascular assessments will show hypertension, tachycardia, and perhaps cardiac dysrhythmias, and these can also eventually lead into cardiac arrest if untreated. In the GI system, they may have cramping, abdominal pain, nausea, vomiting, or diarrhea. So very important, I'm telling you that you need to know these common assessment findings for anaphylaxis. I want to stress here that these patients require continual monitoring and immediate intervention. You are going to be doing repeated vital signs and close monitoring, observing their level of consciousness and wanting to see if they're struggling. Vasopressors often will be needed to be administered here to keep this patient in a good cardiac output. You'll see initial interventions here that are often completed for the patient with an anaphylactic response. And we're always working on those ABCs too, ensuring a patent airway. So have a look through and reading, and these are good for study purposes as well. So there's a wide variety of diagnostics that can be done when investigating allergies, and these will detect abnormalities in the lymphocytes, eosinophils, and immunoglobulins. A CBC with a white blood cell count here will examine the lymphocyte count and eosinophil counts. If this is low, lymphocyte counts means that there's some cellular immunodeficiency occurring. If the eosinophil count is elevated, it can be indicative of a type 1 hypersensitivity reaction that involves IgE. If serum IgE levels are elevated, this is another way to detect that type 1 hypersensitivity reaction, and is often done to diagnose atopic diseases. Sputum, nasal, and bronchial secretions also may be tested for eosinophils. So if the patient is also being investigated for asthma, pulmonary function tests, which you reviewed in the respiratory unit, will be useful in this diagnosis as well. And finally, allergy skin testing can be completed, and that is specific to different types of allergens. So now we're going to have a look at inflammation in wounds, which is covered in chapter 14 of your Lewis textbook, starting on page 223. So when we study inflammation in wounds, we need to consider what's happening at the cellular level. Injury to the cells can occur as a sublethal injury or a lethal injury. Sublethal injuries alter the function, but doesn't actually cause cell death. Lethal injury is an irreversible process that causes cell death, and this happens when there's changes within the nucleus of the cell and there's a rupture of the cell membrane. In a sublethal injury, cellular adaptations take place, which is often a normal part of the physiological process. And this is what these are listed here on the table on the left. The first one is hypertrophy, which is an increase in the size of the cells, and this results in the increased tissue mass but no cell division. An example of hypertrophy would be what you would see in the left ventricle hypertrophy in the heart, and this happens when there's an increase in afterload, and those cells start to become bigger in size because of that overworking. Hyperplasia is an increase in the number of cells resulting from cellular division, and this process is reversible and occurs when the stimulus is removed. An example of this would be the hyperplasia that occurs during pregnancy with the uterine muscle. After the stimulus, which in this case is the fetus, is removed, the uterus returns back to its normal size and state when that stimulus is removed. Atrophy occurs when there's fewer cells or reduction in the size of the individual cells. So this can be from inadequate nutrition, it can occur of aging, or a loss of innervation to the area, so the cells basically start to shrink. A good example is this is if you've ever seen a limb when someone has had a cast removed and there's a bit of muscle wasting from not using that limb occurs. Metaplasia is the transformation of one cell type to another, and this can occur in response to change to a physiological condition or an external irritant. So stress or injury can cause these changes to happen, and again, these can be reversible. An example here would be a chronic smoker and their bronchial epithelium changes to a squamous cell epithelium, or that cell later can become cancerous. So dysplasia is an abnormal division of dividing cells that results in changes in their size, shape, and appearance. And dysplasia is usually a precursor to malignancy, but is reversible again if the stimulus is removed. Anaplesia is a cell differentiation in which more immature or embryonic forms, and these cells could be seen again with malignant tumors. When we look at lethal injuries here in the next box, there's this, remember, is when there's actual cell death. So there's different causes that can lead to this cell death, including hypoxia or ischemic injury, which you're very familiar with, that lack of oxygenation, in which a compromised cellular metabolism occurs that leads to cell death. It can occur from extreme heat or extreme cold or radiation, as well as electrical thermal injuries. Mechanical trauma, so things like abrasions or scraping of the skin, such as in lacerations where there's severings of the blood vessels. And this includes skin contusions, which are like bruises, in which the tissue becomes crushed. So there's hemorrhaging that happens underneath the skin, can cause cell death in that area. Chemical injuries like burns can do this. Microbial injuries that can occur from viruses or bacteria. Immunological examples here would be your antigen-antibody response or an autoimmune response. Neoplasic growth or uncontrolled growth of cells can occur this. And normal substances can cause cell death. So for an example would be if digestive enzymes or uric acid, like the digestive enzymes leak into the abdomen, it can cause peritonitis, or if uric acid crystals start forming in the joints, and this happens when patients have gout. So cell injury. So individual cell death is normal, and this happens all the time in some regenerating tissues. So the skin, the gut, the epithelium, and it also occurs during embryogenesis. So that programmed cell death is termed apoptosis, and it's the normal or expected cell death that occurs to maintain homeostasis in regenerating tissues. Cell death is not normal when it comes to developed tissues. So if you're seeing cell death in normal developed tissues like the brain or the liver, this is what we term as necrosis, and that's cellular death that's occurring there in places it's not supposed to be. Necrosis is what we refer to as that tissue death that occurs from a traumatic injury, infection, or exposure to a toxic chemical. In your Lewis textbook on table 14.2, it goes through the different types of necrosis. The first one's the coagulative, and that's what we see in patients that have that ischemia to the myocardium. So a myocardial infarction would be a coagulative necrosis. Liquefactive occurs with bacterial infections. So think of this as being where pus starts to accumulate and the tissues liquefy. An example here would be like when you have an abscess that has pus inside of it. Caseous are like a cheese-like necrosis, which would be seen in things like tuberculosis, where there's big chunks of debris that don't really look like cells anymore. Gangrene necrosis can be wet gangrene or dry gangrene. So the wet gangrene is when there's a sudden loss of blood flow. So this happens with burns or crush injuries. And the dry gangrene is when there's more of a gradual decrease in the blood supply. And this is what you see with patients, say, for example, with peripheral vascular disease, and they don't receive that oxygenation and the tissues almost basically start to rot. In examining the defense against cell injury, we look at the different vascular response and cellular responses that happen. So the inflammatory response is a sequential reaction that happens from cell injury that neutralizes and dilutes the inflammatory agent, removes the necrotic materials, and establishes an environment suitable for healing and repair. The inflammatory response can be divided into the vascular response and cellular response, and there's also then the formation of exudate, and then healing can occur. The vascular response results in vasodilation, which causes an increase in blood flow to the area and raises filtration pressure. During the cellular response, neutrophils and monocytes move to the inner surface of the capillaries and then through that capillary wall to the site of injury. The complement system also mediates inflammation and destroys invading pathogens. The complement system is that cascade of enzymatic reactions that enhance phagocytosis and also increase the vascular permeability and chemotaxis, which basically just directs the cell to a chemical and cellular lysis. Prostaglandins and leukotrienes here are also mediators of the inflammatory process, which becomes important when looking at the various drugs that work to reduce the inflammation. Exudate then here forms in response to the inflammatory process, and this consists of fluid and leukocytes which move from the circulation to the site of the injury. The nature and quantity of the exudate also depends on the type and severity of the injury, as well as the tissues that are involved in the injury itself. So this can result in serous fluid, which is that clear fluid that you often see early in the stages of inflammation or when an injury is mild. An example you would see that would be like in blisters or in a pleural effusion. Catarrhal exudate occurs when the cell produces mucus. Mucus production is accelerated by the inflammatory process, and an example, a common one would be seen here like in rhinitis or a runny nose, which for example occurs in an upper respiratory infection. Fibrinous serous occurs with increasing vascular permeability, and a fibrinogen then leaks into the vascular spaces, and this occurs with adhesions. Purulent or pus exudate can occur here, which consists of white cells, microorganisms, dead cells, and debris, and this is what you would see inside of an abscess. Hemorrhagic exudate can occur when there's a rupture or necrosis of a blood vessel wall, and for example, you could see this with a hematoma. So looking at clinical manifestations of the inflammatory response, this is when you're going to see that redness, pain, warmth or heat, swelling, and loss of function. The systemic manifestations here are due to that leukocytosis and left shift. You're going to see this result in malaise, anorexia, fever, tachycardia, and tachypnea. And causes of these manifestations can be related to the complement system and the release of cytokines from the red blood cells. Interleukin 1 and 6, as well as tumor necrotic factors, are all cytokines that are generalized that generally cause the symptoms of the inflammatory response, such as malaise and fever. When there's a rise in the body temperature, it increases the heart rate and the respiratory rate, and that's why you'll often see those things happening simultaneously. So the febrile response is when there's a release of the cytokines, which initiates the metabolic response, which stimulates the hypothalamus, which is the control center for body temperature. The hypothalamus will activate the autonomic nervous system to increase the muscle tone and shivering and to decrease blood flow to the periphery. Epinephrine will also be released from the adrenal medulla, which will increase metabolic rates and cause the patient to feel chills, and then they'll start to shiver. And this is the body's attempt to try and raise that temperature. So with the raised body temperature and the cytokine release, the body's defense mechanisms become activated, and this helps to kill the microorganisms by increasing phagocytosis by neutrophils and increased proliferation of the T cells. So it's important to know the different clinical manifestations that can occur here. So there are three basic types of inflammation: acute, subacute, and chronic. In acute inflammation, the healing occurs in 2 to 3 weeks and usually leaves no residual damage. Neutrophils are the predominant cell type during this stage. In the initial stage, you'll see edema at the site of the injury. In subacute inflammation, there are features of the acute process, but it also lasts a bit longer, so this can persist to weeks and sometimes even for months. In chronic inflammation, This can last for weeks, months, or even years, and the predominant cell types at the site of inflammation here are lymphocytes and macrophages. CRP, or C-reactive protein, is an acute phase protein that increases during any inflammation within the body. So they can draw this lab and use it as an inflammatory marker, and we use this one for monitoring the progression of disease. And if you've taken care of COVID-19 patients, you've seen this probably done on them. So now we've reached the last part of the inflammatory process, or the inflammatory response, which is the healing process. Healing includes two major components that consists of regeneration and repair. Regeneration is the replacement of lost cells and tissues with cells of the same type, while repair is a more complex and usually more common that results in a scar tissue formation. What happens is when primary intention takes place, the wound margins are nearly approximated, and you see this usually in like a laceration or a surgical incision. They're able to close them and they fit together well. In the initial phase of the healing, what will happen is that in about the first 4 days, when vasodilation leads to that increased blood flow, it causes warmth, redness, swelling, and loss of function to the area. Granulation is the next stage that occurs, which it usually is between 3 to 24 days, in which new blood vessels and tissue develops around the wound, and it becomes smaller as it heals. The next stage is maturation, and in this phase, it can last from day 24 and even up to 1 year. And in this one, scar tissue is formed. The wound is still at risk here and should still be protected. Secondary intention healing occurs in wounds that are like from trauma, ulcerations, or infections or have a large amount of exudate. These incisions themselves are wide and cannot be pulled together to stitch easily in a straight line. They may have irregular wound margins and have extensive tissue loss, and the edges may not be able to be brought together at all. Tertiary intention healing is also referred to as delayed primary intention healing, and this occurs when there's delayed suturing of a wound where two layers of the granulation tissue are sutured together. In diagram A on the slide at the top, you can see is primary intention. So it's a nice clean wound, the edges come together, and it just leaves a little bit of a scar. In diagram B, you see secondary intention. The wound is a bit uglier looking, it's irregular, large, there might be a blood clot in there. The granulation fills in the wound from the bottom, almost see, or inside as it comes around, and it leaves a scar tissue. In C on the bottom, there's tertiary intention, and it is even worse. The wound here may become contaminated and it can't heal over properly. Granulation tissue forms around the area and then it's sutured together to try and close the wound, but it isn't a delayed closure. There are also several variables that can be used to classify wounds. They can be classified by the cause, so they can be surgical or non-surgical. They can be acute wounds or chronic wounds, and they can also classify them on the level of contamination that's present. The depth of the tissue affected can also be a classification, being superficial, partial thickness, or full thickness. And another one sometimes that used is clinically to classify open wounds is based on the color of the wound, be it yellow, black, red. So you would be looking this and assessing the factors when you're doing wound assessment and also documenting it. So Alberta Health Services has a great resource called Clinical Care Topics, and wound care is one of those topics. So when you're at the hospital, you can log on to Insight and look at this information when completing wound care. And this table basically shows you the different tissue types which can be used in your documentation when you can't sometimes find the words to make it fit for what you're doing. So for example, if there's granulation, slough, necrotic tissue, it helps in your charting and how you would describe it. So when you're removing the old dressing from a wound, you need to assess how much exudate is there on the dirty dressing. Again, using the descriptions and how to describe the color and the drainage. So is it green? Is it purulent? Is it sanguous, serosanguous? And then also the amount, so how much of the dressing that it's covered. Is it saturated? Is it dripping? So when we look at the healing process, there's also factors that can delay wound healing. Such examples can include inadequate nutrition or tissue perfusion and inadequate tissue perfusion, which can occur in low blood supply or, like we just learned about, as an anemia. Smoking is also a known cause for delayed healing as well. Medications such as corticosteroid drugs have been linked to delayed healing, and it's also seen in advancing age, obesity, and diabetes. Any type of mechanical friction can lead to delayed healing, as well as excessive moisture, and this is why we always want to keep our wounds dry and intact, our dressings dry and intact. Other complications impeding the healing process can include adhesions, contractures. In dehiscence, this is what we see when the two sides of the wound are not well approximated, or they have been well approximated and they start to come apart. If there's an excess in the granulation of new tissues, it can also complicate healing. A fistula formation or tunneling if the wound becomes infected, as well as if there's a hemorrhage or any form of hypertrophic scars or keloids forming. So when we're caring for patients with a wound, we must take the patient's labs into consideration to what's happening. This can help tell you if optimal opportunity for healing is present or if there's factors affecting healing. When you complete your wound assessment, think about what labs have been ordered and how it's going to help you with this. So with anemia or low hemoglobin levels, you may see a delay in wound healing due to the lack of perfusion with oxygen. White blood cell count elevation, as you know, is indicative of leukocytosis and infection. And platelets can tell you about thrombocytopenia. CRP, erythrocytes, and sedimentation are inflammatory markers. Even if they're non-specific to where it is in the body, they can tell you about the generalized inflammation that's happening. Urea and creatinine are important because high urea levels impair wound healing, and renal function is important when patients are on antibiotics. Poor renal function can result in edema, so your renal failure patients need to be watched specifically closely and how their wounds are healing. Albumin is something that also needs to be watched because protein loss delays healing, and this might be something you can look at in your liver patients. Uncontrolled glucose inhibits wound healing, so good glycemic control is important in your diabetic wound patients, so it should be monitored. And copper, not a commonly drawn one, but is another one that may be something to watch for, as deficiencies can impair healing. So if wound infection is suspected, wound cultures can be completed to ensure that the pathogen is being effectively treated by the right antibiotic. So in summary, in this presentation, we have reviewed the normal immune response, the cells involved, T cells and B cells, antigen and antibodies and cytokines, humoral and cell-mediated immunity, age-related changes, anaphylaxis and allergic reactions, defense against cell injury, and the healing process.